Well, let us look to the Lord for a wonderful day today. Precious Heavenly Father, we look towards you. We thank you for giving us a wonderful day. We commit this entire day, and especially this special moment. We commit Aditya R. Pillai, Dr. Aditya R. Pillai, into your hands. May she be able to enlighten us about the special things that she has prepared for. Help us, Lord, to listen to her and give us the wisdom to understand how to apply all these things in our daily life as well as our academic career. We commit the entire session into your hands, and we thank you in the name of our Lord and Savior Jesus. Amen.
Let me introduce the speaker for the day, Dr. Aditya R. Pillai. Aditya works as research scientist in the cytogenetics wing of a Central Research Laboratory. And she is actually a postgraduate in microbiology, but then she completed her PhD in nanotechnology from Amrita Institute of Medical Sciences. And then she moved to the field of cytogenetics. She was awarded the postdoctoral fellowship from the Smile Train, New York, and for her work related to genotoxicity in cleft lip and palate in Central Kerala. And she continued as the postdoctoral associate in Jubilee Center for Medical Research, Jubilee Mission Medical College, and continued her work in genotoxicity. And I'm happy to share that she played the pivotal role in establishing the cytogenetics lab in support with the support of Department of Anatomy and Pathology in our own institute. And I'm really happy to introduce you to her, you to all of you, and welcoming Dr. Aditya to deliver her speech. Thank you.
Good morning all. Thank you for coming here. So thank you Anjali ma'am for that introduction. So I belong to the cytogenetic wings of Central Research Laboratory, Believers Church Medical College and Hospital. So today I am going to discuss on the topic genotoxicity, implications and future direction in public health. The term genotoxicity is familiar to almost all of us, right? Because this is the era of genetic diseases, or clinicians are more keen to observe the genetic material, going deep down into the genetic material, the mutational studies, everything. With the advancement of technology, as we have now various sequencing methods, exome sequencing, introme sequencing, so you can see the genetic makeup of a patient and then you can decide the diagnosis. The healthcare system is like that now. So here, genotoxicity is actually playing a vital role. Sequencing will tell you the codons or the sequences or the makeup, genetic makeup of a patient, but genotoxicity will tell you how it leads to mutation or what is the cause for the mutation. So the definition for genotoxicity is actually property of chemical agents that can damage the genetic information within a cell which leads to mutation. So by doing a genotoxicity assessment or evaluation or assay in patient, it will tell you how the DNA has damaged, what caused the breakage and what is actually leading DNA damage to mutation. So this is actually a bridge between the disease and mutation. So these are the events for genotoxicity. So when we can say that the patient is genotoxic, so these are some of the events. First one is DNA repair mechanism. So if there is no DNA repair mechanism or if there is abnormal DNA repair mechanism, then you can say that the patient is genotoxic or there is a genotoxicity. Second one is point mutation. So as I told earlier, if there is a abrupt sequence, or if there is a deletion, insertion of sequences, so which is known as point mutation. So if there is a point mutation in the sequence, that means there is genotoxicity. The patient is genotoxic. Third one, DNA adduct formation. If there is abnormal structures on the DNA have coiled up or curled up. So these are adduct formation. So in that situation also, there is genotoxicity. Then DNA fragmentation. Usually you need only one stretch of DNA, but here the DNA has broken down into pieces. That is DNA fragment. So then again, that is genotoxic. Then the micronucleus formation. So not only direct DNA involvement, if there is abnormal cell cycle, if there is abnormal spindle fiber formation, if there is abnormal chromatid breakage, then also that is also considered to be a genotoxic event. Mechanism. So genotoxicity can be caused by anything known as genotoxicant. It can be a drug, it can be overdosage of drug, any unwanted enzyme, or any antibody, antigen. So genotoxicant can be anything. So it have two type of mechanism. Either it will affect on your DNA directly, or non-DNA, that is indirectly. So in the direct DNA involvement, as I told you, there can be lesions on DNA such as adducts, breaks, or damage. It will lead to mutation. So genotoxicity is leading to mutation. So mutation, again, it can cause the involvement of gene, chromosome, or genome. In the indirect thing, either the enzyme for DNA repair is getting interrupted, or the enzymes are not formed, or there is a abnormal mitotic spindle division, abnormal cell cycle. So, but the scenario is everything is leading to the mutation, apoptosis, and self-proliferation. So, and the final result is carcinogenesis. But not only carcinogenesis. So earlier it was said that genotoxicity will lead to cancer. But now the scenario is not like that. It can cause cancer or any hereditary effects which can result in genetic diseases in offspring, or any developmental toxicity during pregnancy. So if you have a genotoxic event during pregnancy, it can lead to developmental toxicity. So yeah, so how this genotoxicity is causing so many chronic diseases? So the answer is this: because the genotoxic risk, DNA damage or anything, it is actually either it is affecting somatic cells or germ cells. If it is affecting germ cells, the result will be multifactorial diseases, genetic diseases, infertility. And if the genotoxic event is happening inside the somatic cell, then the result will be cancer, cardiovascular diseases, and so many. So that is why genotoxicity is now responsible for almost all chronic diseases. So World Health Organization has actually published in 2019, they have actually given the guidelines for genotoxicity assessment. They are actually requesting all the researchers and clinicians to do the genotoxic assessment in order to be sure actually what has happened to the cell, what has happened to the DNA of the patient. So the guidelines has been mentioned in section 4.5 of chapter 14. So they have given all the tests, what are all the tests which we have to do under this genotoxicity assessment. Other countries like European Commission has also came up with their guidelines of genotoxicity assessment. So there they are actually using these guidelines in many industries, many fields like cosmetics, chemicals, veterinary drugs, and pharmaceuticals. So pharmaceutical is actually, they are more giving importance to this field because genotoxicity is actually playing a major role because of the upcoming newer drugs. So we have to really look into the genotoxic events or genotoxic effects of these drugs. Next one is OECD. This is actually again under this OECD there are a few countries which are also giving their guidelines for genotoxicity. So they all are actually giving importance for the importance in patient care. So like clinicians should actually encourage for genotoxicity assessment. They should actually encourage patients to give samples, and we have to actually check for the genotoxicity events happening in the cell. Yeah, so in the guidelines, these are some of the basic or standard assessment or measurement of genotoxicity. So first one is comet assay, micronucleus test, chromosomal aberration test, ladder assay, and tunnel assay. So first one, comet assay. So comet assay will actually give you the measurement for DNA strand breaks in individual cells. So by comet assay, you can see the DNA damage in the sample. Micronucleus test, again, it will detect the chromosomal fragments in dividing cells. So it will tell you the number of micronuclei formation, the number of nuclear bridge formation, number of nuclear bud formation. So these all are actually abnormal structures, unwanted structures, or you can say. So micronucleus test will tell you or will give you the measurement for that. Then chromosomal aberration test, in which karyotyping is one of the basic thing. Then microarray FISH. So this will give you, this will tell you actually the structural changes in chromosome, whether there is 46 chromosome or whether there is addition of chromosome, whether there is deletion of chromosome. So that is coming under chromosomal aberration test. Then ladder assay. It will tell you the pattern of DNA fragments. Suppose if DNA has broken down into different pieces, so ladder assay will show you that different pieces. Then tunnel assay, so which again it will tell you the apoptotic cells. Apoptotic cells by labeling the DNA fragments. So these are the standard protocols approved by WHO. So if you are doing these assays in order to measure genotoxicity, so, and if there is a positive result, that means your patient is genotoxic. There is genotoxic events. And I also wanted to share that in our cytogenetics lab of Believers Church Medical College, we have actually standardized 2-3 assays, and tunnel assay and ladder assay is actually ongoing process. So sooner we will standardize that also. So that means Believers is having this facility of doing genotoxicity assay. So these are the pictorial representation of all the results of this assay. Now I just wanted to share my experience of doing genotoxicity assessment in patient sample. So I did this work as a part of my postdoctoral work, which was funded by Smile Train in New York. So here we actually looked upon to the genotoxicity assessment or event of cleft lip and palate patients. So our sample size was 1,000. So we were able, so it was a trio study. We were able to collect the samples from the father, mother, and cleft lip affected child. So the result, our findings was, mother and father were actually not genotoxic, but the baby was genotoxic. The frequency of micronuclei, the frequency of nuclear bridge, and frequency of nuclear bud was more in the child. That means something is causing the genotoxic event inside the fetus. So there is some mutation or some genotoxicant is actually causing mutation in the baby. And one more, like fascinating findings of our result was actually, of our work was, this micronuclear formation was actually leading to mutation of 10 genes. Earlier, in cleft lip and palate, there was only involvement of IRF6 gene. If you browse in Google or PubMed, you can see there are several papers on IRF6 genes mutation in cleft lip and palate. But our result was actually supporting that the micronuclear formation, all the abnormal cell division was actually leading to mutation of 10 genes in these patients. And also we did the GIS, Geographical Information System study, where we found that these, actually the 60% of patients were belonging to a particular place in the northern Kerala. So maybe then we actually plan for doing some other chemical test or some metal toxicity in that area, but unfortunately it was not happened. But that means there is something is actually causing a genotoxicity in the mother, but the mother doesn't have any genotoxic event, but the baby is having. So that was my postdoctoral finding in this work. So it was also, the work is actually accepted by the MDPI. And now actually the Smile Train New York Association is actually thinking for advanced interventional therapeutics for this cleft lip and palate, because now they are thinking that, yeah, this is a high time to have a precision medicine or precision therapy for these cleft lip and palate children. And this was also another work where I was a part, and half of the work was done in Jubilee. So again there we have found more micronuclear frequency in recurrent pregnancy loss females. So this work is actually accepted in International Journal of Infertility and Fetal Medicine. So again, this was like the patient with recurrent pregnancy loss is having more number of nuclear bridge. That means there is a chromatid breakage happening during the cell cycle. So maybe that is a reason for the recurrent pregnancy loss or abortion. Now we have actually planned for a wider work to see all the genotoxicity assessment in recurrent pregnancy loss, which is leading to infertility. So that work will be now, it will be done in Believers Church Medical College. We have already taken the IEC from BCMCH. So we are hoping for a big result from this. Yeah, so now I just wanted to share you regarding this mission program. So this is actually an initiative of Government of India by Department of Biotechnology. So the name is PRAGAD. Actually, this is actually a rare disease program on rare genetic disease. So 70 million Indians are suffering from rare diseases. Actually, clinicians are finding it difficult to diagnose what to do with these patients. So we have nearly 40% of patients suffering from rare genetic disorders. So now India has came up with a pan-India mission that they will have a resource centers in each state. So and there is a group of scientists and clinicians. So whenever if a clinician is coming across with any rare genetic disorder patient, now he or she can give the sample to us. We will do the genotoxicity assessment and we will send the samples to the PRAGAD center. So in Kerala, the PRAGAD Research Center is RGCB, Rajiv Gandhi Center for Biotechnology, and the in charge is Dr. Moinak Banerjee. We already had a discussion with him and he is actually ready to collaborate with BCMCH. So now it will be like, if we are coming across with a rare genetic disorder patient or baby, we'll be taking the sample, or like you have to refer the sample to us. We'll be doing the first stage, that is genotoxicity assessment here, and we'll be sending the sample to RGCB, where they will do the all mutational study and will tell you which rare genetic condition is this. And this is how they can, like, we can document a new disease. So this is the pan-India mission of PRAGAD, and I have actually participated in their program also. So this is what India is looking before in terms of PRAGAD. So this is a data which I got from WHO. So they have actually listed out some major diseases which is a cause of mortality in developed countries. So you can see the DNA damage involvement. So they have done a case control study and the data are statistically significant. That means these diseases are having a DNA damage. You cannot say that there is no genotoxicity. There is a genotoxicity, and now we have to really look upon it. Like, at what stage or what is the genotoxicity, or which cell is actually affecting, how much, like how many DNA breakage are there, or what is actually causing a DNA breakage. So now this is actually a whole result of genotoxicity assessment is pointing out to one thing, that is personalized medicine. So for this personalized medicine, there is a need of genotoxicity assessment. As we all know, most of us know what is personalized medicine. So it is like, due to our genetic material, the same medicine will not work to all individuals. So that is why the term this has now in limelight, personalized medicine. So we have to really think on personalized medicine, and for that you have to do a genotoxicity assessment. For personalized medicine, genotoxicity assay will help you. As we all know, without precision medicine, some benefits, other do not, and with precision medicine, each patient will benefit. So in order to put this precision medicine terminology forward, the basic or the fundamental thing which we need is the genetic assessment or the genotoxicity test, all assessment. So this for this only. So this is the future. This is the future of public health. So from genotoxicity, the genotoxicity can lead you, or it can be a bridge between patient and precision medicine, or patient or personalized medicine. So in precision medicine, now we can think of newer strategies. For example, if suppose your patient is genotoxic, if there is a DNA damage, we can think of these strategies, right? Like protective agent, supplement, cytoprotective agent, chelation therapy in case of metal toxicity. If the patient is belonging to some area where this mining is happening, these quarries are there, and if you are seeing, if you have observed that there is a metal toxicity, due to this metal there is a genotoxin, then we can go for a chelation therapy. Then hydration, diuretics. Then the important term is advanced therapeutic intervention, that is gene therapy, stem cell therapy. If at all, if there is a need of DNA to be replaced, we can go for a CRISPR-Cas9 technology, because now all the Western countries are having this gene editing. If suppose there is a need of editing a gene, the gene is damaged, the DNA is damaged, we can go for an editing thing. But unfortunately, India is lacking behind in this run for this advanced therapeutic intervention, but hopefully within 10 years, we will be in the front list. We have to think for this advanced therapeutic intervention, because this is the future of healthcare or future of medicine. So I wanted to conclude my presentation. So finally, I just wanted to say you that as you all clinicians, you have to really think of newer methods, newer technologies, newer ideology for the patient care, and where we can help you by doing this kind of assessment. We can tell you actually what is happening inside the patient's body, what is actually happened inside the patient cell. Thank you.
Thank you, Aditya, for giving us an insight into the various implications of cytogenetics lab. So can we have any questions now?
Aditi, thank you so much for that presentation. I happened to go, Cherry, to the lab where she worked. So it's a fantastic lab. I'm sending a whole team from here at the Jubilee Mission Medical College Hospital. They have a beautiful facility there. I've requested Anjali and Cletus to go there and copy that whole thing here. It's a very well planned out lab. The question to you, Aditya, is, we understood what you said, but the problem is when it comes to practice, how do we, Dr. Thomas is here? Yes, the medicine people, oh, sir is here. Welcome back. Welcome, good to have you here. How do we translate that today? Futuristic, fine. Gene therapy is something that we've been talking about for the last 20, 30 years. Where are we today with gene therapy?
So actually, I won't say that there is no gene therapy in India. There was an article from Amrita. So actually they have in some renal diseases, actually they have implemented the gene therapy with CRISPR-Cas9. Dr. Sanjay Pal from Amrita School of Biotechnology was head. So actually he did a CRISPR-Cas9 gene editing in the patient. It was actually, it was in the newspaper also. So we have to actually get a help from all the different scientific group to know like how to do a gene editing, how to do a CRISPR-Cas9. So if we come together, if we become a team of molecular biologist, gene editing team, definitely we can go for a gene editing therapy for some, at least for some chronic diseases. And even in RCC also, they are actually now coming with gene therapy for some cancer, uterine fibroid cancers and all. They are actually coming up with this gene therapy. So I would say that we should have a team for doing that, and we should actually start this thing. Like, it's been 20-25 years Western countries are doing, but India is still lacking.
So what would be the cost? Like, say, if you're going to choose patients for genetic studies?
So for this, I would say that for genotoxicity assessment, this is not much expensive. Once it is standardized in our lab, if we have an in-house facility, it is not that expensive. Because from for example, from 60,000 rupees kit, we can do 100 samples. So for genotoxicity assessment, this is not actually much expensive. Rather, outsourcing is actually expensive. If we are outsourcing the karyotyping, they are taking 6,000 or 7,000 per sample. But if the facility is in-house, we can actually do it within 3,000 range. So doing it in-house is actually not expensive.
I just want to, one clarification.
Yeah.
Am I audible?
Yeah. Yes. Sir, yes.
You talked about those 1,000 patients,
Yeah, yes,
that
yes.
newborn babies with
Yeah.
a cleft lip,
Yes.
and you talked about genocity only in the fetus, only in the newborn baby.
Yes, yes.
Those 1,000 cases which you chose, do you have any history of those pregnancies, whether they were spontaneous, normal pregnancies, or whether there was any in vitro fertilizations?
No. So actually, the 1,000 were having a normal pregnancy.
No.
We have actually
No.
excluded the IVF ones.
Okay.
Yeah.
Okay. I just
Because-
want to know
Yeah, because
when you are handling the gametes
yes,
outside.
yes, sir.
Thanks.
Because in Kerala, the scenario is IVF patients are having more cleft lip and palate babies. So it's because of some reason which we have not, which we have excluded. Because so the 1,000 mothers were actually having a natural pregnancy.
Can I ask Shahul sir, are there any currently in medicine, are we using gene therapy for any conditions? Not yet, no? We've not got any guidelines yet. Because see, for example, we had this very sick patient yesterday in the ICU. We didn't know what was happening. So is there a role for attempting gene therapy? We still don't have any accepted guidelines, or?
So there is a ICMR guideline for gene therapy. So they are mentioning some, like, it is a kind of 42 pages guidelines prescribed by ICMR. So that is for gene therapy. So we have to really look into that.
Any questions from students? Okay. If there are no more questions.
I also wanted to add, so earlier in 2023, actually Israel has come up with a new drug, that is DDR, DNA damage repair drug. So now it is like there is a medicine which can actually repair the DNA. So it is actually basically promoting the DNA repair mechanism. So now instead of DNA or gene editing, we can go for DDR drugs. So we have to think our own DDR drugs, how we can like have a DDR drug for each and every diseases. So this is a newer thing which scientists are actually looking upon, DDR, DNA damage repair drug.
Thanks. Aditya, can you do one thing? Can you get our clinicians to visit your cytogenetics laboratory?
Yeah,
because
sure.
you
Yes,
had made
yes.
a presentation
Yes,
that day,
yes.
and Dr. John is under the impression that in a month or two, you will roll it all out. That's the impression we had. Okay? Obviously, that's not true. But can you get the clinicians, like
Yes.
what you just said, to come and have a look?
Yes.
And then they will start referring patients or planning with
Yeah.
you.
Yeah, yes. And Dr. Moinak Banerjee has from RGCB. He is very interested. He told me that he'll come and he'll give a discussion with clinicians to refer their some rare genetic conditions to them so that we can have a combined collaboration and combined publication in this PRAGAD mission.
Currently, in severe oligospermia, before we go for any procedures, we do a DNA fragmentation test that we do in our lab itself. And Y deletion. But it is not done here. We are saying, are we going to start?
Yes, sir. Actually, we are. This is ongoing ladder assay. We most probably by this month we'll standardize. So that means we'll have a ladder assay test in house itself.
Thank you all for coming and have a good day.